Hey guys, my name is Beth Stamps. I am a student in the RN to BSN program at the University of Kentucky. This is a video of a teaching presentation and a news article review and a teaching handout for the Concepts of Professional Nursing course. I am a Kentucky resident. I currently live in Fayetteville, North Carolina. My husband is active duty. So due to the area that I live in and I work in right now, I did choose a news article from the North Carolina Medical Foundation where they launched a project called the Office-Based Opioid Treatment. The goal of this project was to establish research-based pilot projects throughout the entire state of North Carolina to increase patient access to opioid treatment and recovery. A coalition of partners came together to input their expertise, and the coalition of partners such as the University of North Carolina, the School of Public Health, the Mountain Area Health Education Center, they came together and expanded the use of medication-assisted treatment, or MAT, in fighting the opioid addiction in North Carolina. There were some statistics provided within the article, and 21 to 29% of patients prescribed opioids for chronic pain will misuse them. Between 8 and 12% will develop an opioid use disorder, and then 4 to 6% who misuse prescription opioids will transition to the use of heroin. Sadly, only 3% of physicians or PAs in the state of North Carolina know about or are trained for the medical assisted treatment program. The office-based opioid treatment program actually provides computer programming to the physician or the PA using MAT to coordinate care for the patient, track noncompliance, and address other determinants of health outcomes and incorporate telemedicine. Telemedicine, if anybody's worked in home health, you kind of know what that is. It is a device that is sent to the home from the company, and per the doctor sets up what needs to be monitored in the home, such as vital signs or any kind of way to plug in with the patient from the doctor's office, so the patient doesn't have to travel to the doctor's office. This project, OBOT, or office-based opioid treatment, assists providers or doctors in North Carolina to prescribe medication-assisted treatments to patients. So going a little bit further into MAT, MAT is prescribing a certain drug along with behavioral therapy and or other social supports to help treat the opioid use disorder. Doctors who do prescribe the drugs that are associated with the medical assisted treatment, they must go through an 8-hour training to obtain a waiver from the Federal Substance Abuse and Mental Health Services Administration. Following obtaining successful passing and obtaining the waiver, the physician may then prescribe only 30 patients for the first year the medical assisted treatment drugs. Then the physician or PA must reapply for the waiver annually. They can prescribe up to 100 patients in the second year, and then on the third year, 275 patients. Drugs approved are methadone and naltrexone and buprenorphine, which requires the patient to use, the naltrexone actually requires the patient to have not used opioids for 7 to 10 days prior. So it goes back to the compliance of the patient and actually following the doctor's orders. The article was an analysis of state policies fighting the epidemic. So the actual statistic and the research was gathered up over approximately a year and a half. The article called for a Medicaid expansion in North Carolina to help with the assistance of the cost of the medical assisted treatment for the drugs. The research for this article wrapped up in September, and it actually praised North Carolina for the multiple steps they are taking to lower opioid use, such as increasing the access to the medical assisted treatment, non-opioid pain management, and the widespread distribution of Narcan throughout the state. There was a picture of the state of North Carolina within the article, and it had little blue dots, almost like pin drop on a map, and you almost couldn't see the actual state because of how many places Narcan is available. During the past year, over 700 physicians were able to obtain a waiver to help prescribe the medical assistant treatment, and only a small amount used the waiver due to the patient compliance. So with the telemed or telemedicine in the patient's home, that allows the patient to plug in and connect with the doctor and not have to worry about travel an hour to an hour from appointments, that may boost the compliance of actually having the MAT. Earlier in the year, the organization formed an independent pharmacy network to accept special pharmacy benefit cards for MAT. This benefit card allowed for the cost of MAT to be cut in half. So it actually made the cost of the drugs for MAT almost as much as drugs on the street or less. So patients would not relapse and seek out drugs on the street. Actually, one of the doctors focused on non-opioid pain management and stated that I'm prescribing, in quotations, yoga for my patients. And I think someone had picked yoga as a non-opioid pain management. So for my actual teaching handout, I did choose cognitive behavioral therapy. You can see that. Cognitive behavioral therapy, I focused on a group of 18 years or older with chronic back pain. I did work in nursing homes for 8 years. I now work in home health. So especially in home health, sometimes we do see a younger or older population that have been injured at work or been injured somewhere at some point in time, and they are now dealing with pain, chronic pain, and sometimes the pain medicine is just not helping. So chronic behavioral therapy, you actually would ask during, like, if we were to sit down, as a nurse, if I were to sit down with a patient, I would have a one-on-one discussion of the meaning of cognitive behavioral therapy and the benefit of the therapy as related to a non-opioid method of pain relief, and establish this by the end of the visit. Cognitively, the patient would translate the meaning of the therapy back to me and begin to understand that it is a means to in alleviating pain, and hopefully do this by the end of the visit with the patient. The patient or family would recognize chronic pain is not just about taking meds, but also treating the way of thinking about how we think about pain by the end of a visit. Patient will express concerns in question format to the nurse or to me of any misunderstanding of cognitive behavioral therapy. If I were to hand this, of course it would probably be a little bit smaller, the patient handout, hand it to the patient or to the family, and they would accept this handout, and they may express, to establish the goal and to achieve the goal, they would express interest and schedule an appointment for cognitive behavioral visit therapy by the next visit if they were to get a referral from their PCP and establish that care. Evaluating how the actual patient handout worked for the patient, and if it were successful and the patient were able to set up, the patient would have expressed to the nurse or to me an alternative, that cognitive behavioral therapy was an alternative means of alleviating pain. The patient would recognize how someone thinks of chronic pain must be treated just as taking pain medication for chronic pain. So not taking pain medicines all the time, but restructuring how someone thinks about their pain and doesn't dwell on it and the pain gets worse. But the family or the patient would share questions or hesitancy of starting cognitive behavioral therapy, and they would do that openly with me as the nurse. The psychomotor wise, the patient and family would accept the handout and take it with them and possibly explore what cognitive behavioral therapy is. Sometimes people are a little afraid to ask questions in front of people or maybe embarrassed. So on here I did explain that, if you are 18 years or older, some of the things that you would establish care with a psychotherapist or therapist and have a patient-centered plan of care. Depending on how much therapy that one person may need for chronic pain, You may go one time, twice a week starting out, and then eventually taper off. But to begin with, you could develop certain things with this therapist, such as relaxation technique, guidance and exercise pacing, behavioral action, and restructuring how you think. Benefits of the cognitive behavioral therapy, I would explain with the patient. If you could get away without having another medical procedure to cause further medical issues on down the road, this is a great benefit. It prevents you from having another medical procedure. And, it's proven to see a reduction of pain and distress, pain interfering with activities, those good old ADLs, and decrease of disability, because people with chronic back pain do sometimes suffer from disability due to that. And then I do give the patient several resources on how to start. Speak with the primary care provider or pain doctor regarding a referral for cognitive behavioral therapy. Have the patient check with their insurance, or if that's something that the doctor's office can do as far as referral wise. Check with the insurance provider to see if they are able to pay for or provide that type of service. And then just encourage the patient, like I said earlier, to reach out on the web and to explore what cognitive behavioral therapy is. I did choose this because like I had stated, I worked in long-term care, and we did have therapy, or I should say a psych nurse come into our facility, and they would help talk with the patients about depression. But then, we also had those patients that we took care of that did have chronic pain, not just in their back, but sometimes chronic pain all over. And we would try to do guided imagery with the patients as a use of non-opioid pain management. And I wish that we had this resource for our patients, that someone could come in and kind of teach them if they were able to, didn't have that diagnosis of not diabetes, but of Alzheimer's or dementia, where they were able to remember and able to take use and benefit from cognitive behavioral therapy. Because more times you dwell on it, the more you think about wanting to take different things or use different ways to alleviate pain. I did choose the state of North Carolina and Fayetteville just because of where I am at the moment. And there's lots of good articles online regarding the opioid use here and the major fight that North Carolina and much more the state and the whole nation is fighting to fight this opioid use and this opioid battle that we have. Appreciate your time. Thanks, guys.